So, da kommen schon die ersten rein. Just for everyone's information, people are still coming in, so we'll wait still a minute or two, and then we'll start with the lecture. So nobody else coming in as far as I can see, so I think we can start. Right, so hello everyone and welcome to the lecture Principles of Aging Medicine for the Rapidly Changing Society of the 21st Century, kindly presented today by Professor Maria Cristina Polidori, both as an opening lecture of the 10th semester of the Aging Medicine and Medicine of the Aged program, and also within the open lecture format of EUniWell, the European University of Wellbeing. First, in the introductions, Professor Polidori is a full professor of aging clinical research at the Uniclinicum in Cologne and focuses in her research on topics such as the impact on lifestyles lifestyles on aging, longevity, or medical research and ethical aspects of clinical decision-making with advancing age. A graduate of the University of Perugia, Professor Polidori has been a research fellow at renowned institutes such as the Harvard University, the Boston University, and collaborates with worldwide leading aging research institutions such as the Swedish Karolinska Institutet and the National Institute of Aging in Baltimore. Professor Polidori also works as an associated principal investigator at the Cologne Cluster of Excellence on cellular stress responses in aging-associated diseases, and is a member of EUniWell's working group for the development of a master's program on health and well-being. Indeed, at EUniWell, we are very happy to have Professor Polidori on board with our projects. EUniWell, the European University of Wellbeing, is one of over 40 European university alliances that have been formed as a part of the European Union's long-term strategy to create a European education area, removing barriers in research, education, and administration, also at the level of tertiary education. We are partnered with the University of Constance, Birmingham, Semmelweis in Budapest, Linnaeus in the Swedish Växjö, the University of Nantes, INALCO in Paris, University of Florence, University of Murcia, and Santiago de Compostela. Our focus at EUniWell is to support research, education, and really the dissemination of knowledge and information in terms of well-being in a context that includes, but also goes far beyond the individual level. Well-being is no longer just a term that one mentions with reference to getting a foot massage, but constitutes a multidisciplinary research area supported and based upon the goals of the European Union to make well-being a central element at the personal, societal, economic, environmental, regional, and also indeed the global levels. Now, against this background, I would like to invite you all to explore our website and the possibilities to participate in events, trainings, and even funding opportunities for your projects, all prepared for you by experts from across Europe. One shining example of our involved experts is indeed Professor Polidori, whom I once again thank kindly for her engagement with EUniWell, and to whom I'll be handing over in a moment. If you have any questions during the lecture, please use the Q&A function that you will see down on the button below, and we will try to get to you as soon as possible during the lecture. So thank you very much, Professor Polidori. Please.
Thank you very much, Mr. Eger, for this kind introduction, and welcome to all the participants to this series on not only of EUniWell, but also on principles of aging medicine. And actually, I'm really happy to be here because, as Mr. Eger says, there is an authentic need and also now opportunity to focusing on quality of life and well-being, which are targets of the health systems, of the European health systems in several years. And thanks to EUniWell, we can reach these targets in a really very concentrated manner. So as Mr. Eger said, don't hesitate to ask or to write in the chat if you have questions, because now you will see in the next one and a half hour how complex this topic is of aging medicine, of the rapidly changing society, and how many challenges, but also opportunities we will have as medical doctors, but also non-medical healthcare practitioners, and also representatives of social humanities, economics, and ethics, and other disciplines to cope with these challenges, to make the world in the next years much more sustainable. Okay, so basically aging, why aging? Aging is a process that is continuous and until now inevitable, and it is, however, modifiable. Of course, what happens is that with increasing chronological age, we have an increasing also vulnerability, and this vulnerability was recognized in all the antique cultures. So I like very much always to show this, because instead of an introduction, to understand how the humankind and not only understood, but also had difficulties with the process of aging. And in fact, I take always as an example, although the antique cultures had always this approach, each one a known approach to the fact that we are vulnerable and that humans will die, and the living organisms will die. The antique Greeks had a personal approach, a particular approach. And so this approach was to reproduce in art their own concerns about aging. And they created many myths, and we cannot go over them today. But if you like history, just go over some of them, like the myth of Eos and Tithonus, or the story of Aeneas and Anchises. And what I would like to draw your attention on is this picture. This is a vase which was painted in the 5th century before Christ, and represents one of the most powerful roles of the antique history and science history in Greece, Hercules, who's combating actually. So this very, very powerful person is combating against this very vulnerable and fragile role represented here, which is actually called Giras. And Giras, it means aging, or the age, advanced age in Greek. And that's why we say today geriatrics or gerontology. And so these are the myths that in the ancient history tried to produce, to understand and cope with the idea that we all die. And today we have another approach. So 26 centuries afterwards, so we talk about the pathway of youth, of being immortal and ending the phase of aging. And we also are working on many therapies and strategies, which actually some of them are very promising. But actually, at the end, if we look at the reality is that one of all these pictures that we are seeing did not change so far, which is the fact that Giras was not really won on, and Hercules is still combating against him. The challenges associated are different in comparison to the last centuries, of course. Why? Because we are facing main changes of the human history, which are in fact represented in some parts here. So first of all, we have in Germany, but this is the trend in all Western countries, we are facing a doubling of the population of persons aged 80 years and above. So the population of very old, the so-called oldest old persons are rapidly increasing, and this will take, of course, we'll have some challenges, and we are also already now experiencing these challenges. So this is one aspect. The upcoming unique challenge of 4 that I will tell you in a minute, and is paralleled by the fact that even if we have all these old people upcoming, even more than now in the next years, if you look here, an 80-year-old person, so in red we have women and in blue we have men, they have about 8 to 10 years life expectancy at this age in potentially complete function. So we have this picture of increasing a population of older persons, but in fact, these are not persons that are about to die, but they have a very long life expectancy. Even a person with 90 years old will expect to probably, if in optimal conditions, to live 4 or 5 more years. So this is very important to know, especially for healthcare practitioners, but also in general for all of those who care about humanities and ethical decisions, clinical decision making, and so on, because we cannot simply go on the wave of the so-called ageism, which is one of the most challenging discriminations of the humankind, like racism or sexism, saying one person is old and with 80, I don't care much. This has a huge implication, because if you will see, and I will show you, that we don't have really representative studies for this old population, which is increasing very rapidly, which allow us, evidence-based, to take proper decisions which concern, for instance, multimorbidity or polypharmacy. So the reason is that most of the old, frail persons taking, for instance, a drug are excluded from the randomized clinical trials that test the effects of the drug itself, so that about 2/3, from 2/3 to 3/4 of the population in studies are excluded from clinical trials, and these are usually those persons who will then take these drugs or these interventions in real life. So this is the picture. What happens is that, of course, if we think that the life expectancy increased so incredibly with increase in the last years, so we mention a doubling of the life expectancy at birth in the past century. At the same time, the disability-free life expectancy, so the life expectancy without disability, did not increase at the same pace. So we have an increasing of the life expectancy at birth and during life, as we see, but we don't have a real increase of the disability-free life expectancy at birth. It is, of course, paralleled by some very positive developments, like the fact that we are having less incidence of diseases like dementia in the new generations with respect to the older generations. But in general, due to the increase of the population, we have high prevalence of these disorders, which are degenerative disorders and highly disabling. So that we talk, and this was a paper published in JAMA in 2018, we talk about the moving from lifespan or life expectancy. These are two very different concepts, but just to understand, we cannot go in detail today, just to understand the concept is that we don't have to much concentrate about survival and life expectancy and lifespan, which is the amount, the maximal length of life for a specific, a particular species, like for instance, for humans, lifespan is about 120 years. Life expectancy today is 84 years. We don't have much to concentrate about survival, but about the quality, the functions, and the quality, the well-being, and the quality of life that we have in this during life, especially at the end of life, because as you see here, we have roughly 10 years to 12 of disability at the end of life, functional loss, which must be compressed and improved. And so our concentration, and this is very much in line with the University of Wellbeing, our concentration has to be on quality. And if you see, I get back to history, to ancient history, and I grasp and I reach the Greeks, to the Greeks again, because they had 4 concepts to understand and describe the concept of time. They had the concept of the day of today. They had the concept of the eternity. They had the concept of this image represented here, which is called Kronos. This is Kronos, one god that, as the name says, had a real big problem with time passing. And in fact, he was so afraid of his future that he was used to eat his own children. And that's so it's the Kronos as the representation of an entity consuming the future. And that's why we say chronology. It's the quantity of time, the time which goes. And but then they also had in the ancient Greece, they had this concept. One of the youngest grandchildren of Kronos is this one. And this god is very different. He's gentle and kind, and this one is rather cruel in his image. And this is, in fact, was the 4th concept of time in Greece, and it was the quality of the time. It's not about the quantity of the time, it's about the right time, the time that you cannot measure, the quality of the time. And this name is Kairos. So Kronos and Kairos are the 2 aspects of our society. We are used to look and to want to remain young and to combat against the time that passes by. At the end, moving on towards the end of life, we have to concentrate on quality of life and not only on survival or mortality. For instance, and I'm talking to the future doctors or the doctors here in the audience, we take decisions about clinical decisions based upon chronological age and comorbidity, and we will see, and we focus on survival. We will see that with increasing age, which is a huge challenge now with most of the persons which needs our cure being aged old or very old, with this increasing age, these parameters are not enough. In fact, if we see at this, in this axis, we see age, increasing age, and health, let's say, or functions. On the Y axis, we are born with the need of increasing our functions to the top, and then at the end, our functions with increasing age decline. And in fact, we have now, this is really not representing exactly what happens today, but we have, as I said, several years of disability at the end of life. At this time, we could increase health span, which is in fact health expectancy until our at least end of the life expectancy. In fact, many researchers worldwide are working on the compression of morbidity or completely the cancellation, neutralization of age-related functional loss and vulnerability up to the exhaustion of our lifespan, which is about 120 years, as I said, for humans. So these are the real challenges. For now, decreasing the morbidity and functional loss, and in the future to being able to maintain our functions at the best possible level until we lived our maximum average lifespan, and then of course at the end without losing functions, to in fact have our lifespan finished and completed. I show you now what are we going through as doctors, but also as citizens when we face the challenges of increasing age. So I will show you now, and this is, I kindly ask you to imagine for the next concepts that I show you during the course of this lecture, to imagine always these three scenarios that I'm going to show you, which all of them represent a patient, Mrs. Lenders, which comes to us. She is 70 years old in all possible scenarios. So I only got three, and we only have time for three quite exemplary scenarios. But you have to imagine that in medicine, especially aging medicine doctors, that we face this kind of differences while the persons have the same chronological age and maybe the same problem physically. Every day, many of these scenarios. So I will show you Mrs. Lenders. She's 70 years old. This is her chronological age. She comes to me for a problem, a minor problem, for instance, knee osteoarthritis. And she looks like this in one scenario.
Please come in. My name is Dr. Smith. Yeah, very good. I'll do the same. So, welcome. Please have a seat.
So this is one scenario. And this is possibly the same person could present like this.
Hi, Mrs. Lenders. Good morning. Nice to meet you. My name is Dr. Smith.
Yes. Hello.
Hello. Yes. So
shall I do
please.
this?
Yes, that's very good. In these times, you know, we have the vaccine, and we are.
And possibly Mrs. Lenders could show up like this.
My name is Dr. Smith. Nice to meet you. Thank you very much. Thank you. Thank you, Dr. Brand. See you later. So, yes. Oh, okay.
So the message is, we are facing an incredibly rapid change of the society, with lots of persons getting old and older. And they are all very much heterogeneous. So if we base our clinical decisions on chronological age and on one morbidity alone or one disease, we will have the problem that we will miss many aspects of this person, which dramatically influence her health trajectories, but fully escape the normal and current diagnostic and therapeutic algorithms. And we have some knowledge about this now, and maybe potentially some solutions. Summarizing this introductory part, this is what is happening at this point to the humankind. One first incredible change is that, and a unique challenge of the human history, is that since the 60s of the last century, older people are getting more in number than younger people. And we have since a couple of decades more 65 plus persons than under 15 years old persons worldwide. The other challenge is on the right. And this is the United States, but this is the same for Germany and for Western countries, and unfortunately also for what we call developing countries, which are now rapidly changing in their structure of the population, which is obesity. So since 2016, we have more overweight persons worldwide than underweight persons worldwide. And I will show you in a more clear way these changes. So this overweight is in fact due to the fact that until now, more or less, until a couple of years ago, and a couple of decades ago, somebody who did not have the chance and had enough money also had less food. Today, we have the possibilities to pay food with less money, and this, of course, is associated with an overweight of the population. The other challenges are summarized here. So in the past century, we had, as I said, basically the doubling of the life expectancy at birth. We had in the past few years, the dramatic increase of the overweight population. In the 60s, the world population doubled in the net way from 3 to 6 billions. And now we are, of course, reaching in the next few years 10 billions of persons. And if you say in these images, also another incredible change is that we are moving from the country to the city, which poses enormous challenges to the concept of urban health. And all these characteristics, plus the one that is coming with the netto doubling of the oldest population, has something in common. One thing is what Bruce Ames, the National Medal of Science, a couple of years ago defined hidden hunger. So the aging and obesity have to do with the deficiency in very important nutrients, which are called micronutrients and trace elements, which cause during the time, if they persist over time, also, of course, disease, but basically frailty and vulnerability against stressors. So the very important role of lifestyle, which is evidence-based, which we have a lot of difficulties on establishing, the focus of medical interventions on the importance of maintaining health through a good lifestyle and a balanced diet. Frailty is called geriatric syndrome. But actually, we have quite a lot of problems in understanding what frailty is and in operationalizing its definition. And some of the most important geriatricians worldwide defined frailty as the very intrinsic way of becoming old, independently of chronological age. And in fact, frailty is a condition that poses us on this kind of razor, and we have to maintain the equilibrium. And if you remember the image of Kairos, Kairos is staying on a very thin line and has also wings on her foot, on his feet, because he has to maintain the equilibrium. And the equilibrium is about maintaining quality of life and functions. And the Greek, the ancient populations knew that. William Adler says, perhaps my most typical patient of a geriatrician is the old-fashioned picture of frailty, a man, or more often a woman, who lives on the razor's edge between independence and triggering a tragic cascade of diseases, disability, and complications that all too often prove irreversible. So as a geriatrician, I'm by definition an expert in subtlety and complexity. And Walson and Ferrucci, which worked a lot, are experts of frailty, say the cornerstone and even raison d'etre of geriatric medicine concerns the identification, evaluation, and treatment of frail older adults and prevention of loss of independence and other outcomes for which they are at risk. So frailty beyond medical constructs is a concept. It's the concept of the intrinsic pace of age, which is independent of chronological. It goes together, but it's mostly independent, as we saw with the patient, Mrs. Lenders, independent of chronological age. This person, and we will not go through this today, but in the next lessons in presence at the University of Cologne, we will go through this cascade. So the compensation cascade that can happen if we don't recognize vulnerability in our patients and we let them actually fall down from this razor. And this is when we don't recognize, it's very small written and we don't have to go through this. So when we don't recognize their actual biological age and potential, then we have a high risk of producing another syndrome, which is called iatrogenic syndrome, and which is due to the fact that we don't recognize something that is potentially preventable. Vulnerability. This is defined, like frailty, like a long-term condition characterized by multiple decompensation across multiple systems and vulnerability, decreased organ and system reserve to the compensation after a stressor event. So an increasing vulnerability to stressors. And the fact is that this continuum of frailty from fit, a person which is robust and fit, to mild and moderate and severe frailty is a continuum of a spectrum disorder which is really not recognized in clinical routine. And this is really important that we learn to do that. And to do that, we have to know what frailty is and to know the instruments that are available. The functional ability, which I showed you before, enables us to be independent. There is a minor illness which we cope with and we don't have any problem, we recover. But in sometimes we don't recover, we go under a particular threshold, which is individual, unfortunately, and dynamic and very difficult to detect. There are no metrics for these thresholds at this moment. And we then go in the dependency, and then accordingly to factors that we are working on, but that we don't know exactly in their full spectrum, we can recover or not. And this is really, at this point, quite unpredictable. I'll show you the instruments that we have to predict this, but we are talking about prognosis. We find ourselves in a topic which has difficulty struggling in understanding, in getting evidence. As I said, because many of these patients, which are real life patients, are excluded from clinical trials. Okay, so I decided to show you what happens, because this fits very well to the open lecture of the University of Wellbeing. What happens by giving you a very practical experiment, which I had the honor to perform when I was at your age. So I was 21 in Italy, in a very small center in central Italy. And in this center, in this small part of Italy, started one of the recruiting sites of the first worldwide multicentric study on centenarians. And what happens is that I visited these centenarians at home, and we performed a very comprehensive assessment, including blood withdrawal and measurement of some substances. And you can find many papers on the Italian multicentric study on centenarians. And then at the end, I had the idea, because I did not, I had not finished the medical school, of course. So I was curious, and I wanted to develop a research question of for myself, how to become and healthy centenarian. To those, I asked them, I asked this to those people who were really healthy, at least phenotypically. And they answered these questions here. Most of them: live and let live, work a lot and be happy, wake up early. At that time, they were not used to work like we work today, so it was 30 years ago. Don't sleep during the day, because they were used, like in the Mediterranean world, to work while the light, the natural light is there. So don't sleep during the day, read a lot, keep interested, don't get upset, don't care about what other people do, and keep a focus in life. And now all these aspects have other names in science, and they have really a terminology, but this is what they said. From a medical and clinical point of view, all of them answered: eat lots of vegetables. Well, actually, they said cultivate them yourself. Eat less, but choose slowly. Be outside, walk and exercise outside. Drink a glass of wine, they said red wine, per day. And this was long before the polyphenols in chocolate, in onions, and in red wine were discovered. Always eat at the same time. And in fact, now we have working group of the World Health Organization working exactly on these aspects for disease prevention. The Mediterranean diet, which is not an Italian diet, it's just a diet, which it means lifestyle, not only nutrition, of the Mediterranean region, is a world culture heritage of UNESCO. And top 10 burdens of disease and causes of disease at this time are due to these aspects related to lifestyle. Last but not least, in these centenarians, we found levels, plasma levels, concentrations of some vitamins like vitamin A and vitamin E, independent of nutrient intake, much higher with respect to younger persons, healthy, mostly siblings and children of the centenarians. So persons that were in fact shared the same genes. Okay, so this is really about lifestyle. And now we know through the twin registry, we know that 70% of the diseases are caused by lifestyle and wrong nutrition and a poor lifestyle. Okay, so in fact, if we look, and now we have other research working on these other kind of studies, centenarians are basically, if we zoom in the blood and the molecular characteristics of the centenarians, we recognize that they are like caloric restricted persons. So like persons who really undergo caloric restrictions and diet, and they have very similar glucose metabolism, blood pressure, steroid levels, lipid profile, body composition, metabolism, than like calorie restricted diet people of much younger age, between 20 and 60. So this is what I would like to give you as a message, the importance of lifestyle and nutrition to stay healthy until 100. And in fact, if we look at nutrition, nutrition is correlated to health, to quality of life and well-being, longevity, cognitive performance, physical performance. The mechanisms are multiple because nutrition improves a number of factors associated with the onset of disease, like inflammation, glucose homeostasis, energy metabolism, oxidative stress and distress, circadian rhythm. And we have many, many studies, and we coordinated also many special issues of important journals. This one just came out on nutrients, so you can go ahead and look at these papers that deliver the evidence of the importance of nutrition. if I give you in this moment a snapshot of, however, what happens is that only about 1/4 of, for instance, the German population, but in general in the Western countries, have such an healthy diet that they can be covered and protected against nutrition and malnutrition related diseases. So we are talking about a very important phenomenon. I open a bracket. If we eat healthy, and I'll show you later on at the end of this lecture what we do in Cologne, for instance, to help this global health approach to health and disease. We have, if we eat properly and in a balanced way, we do good to our health and to also the environment, our planet, and also the animals. So we are talking about really global health and planetary health. In fact, if we the adoption of healthier dietary patterns would simultaneously improve health outcomes and decrease diet-related mortality by 1/5 and diet-related environmental impact by 60% at least. And this is probably underestimated. Okay, we have a problem with this. And the problem, I explained you this problem of, at the end, one could say, yeah, so we organize our lifestyle, and this is it. The issue, not a problem because it's never too late to solve important issues in medicine, but the issue is with the example of dementia, for instance, very clear. The issue is of the lifelong exposition. In order to stay healthy during life, we need a lot of time, and we have a basic. We must adopt a lifestyle which is continuously healthy and not only 1 week or a couple of days and then back. And in fact, it's not only if you look at an unhealthy diet, this is only one of the many risk factors for dementia, but also for most of cardiovascular diseases, also for the so-called civilization diseases, the majority of the chronic diseases and age-related diseases. Unhealthy diet is one factor, but also other substance abuse factors, chronic diseases like diabetes or depression, blood pressure, obesity, high blood cholesterol. All these factors converge and merge into the cumulative disease risk. Age-related diseases have similar mechanisms most of the times. In fact, concur to the fact that dementia occurs many, many years prior to its clinical onset. So we have to start very early in life. And this is what we have to do as medical doctors to counsel our patients, not only waiting until they are ill, but always counseling about health and well-being and quality of life and healthy maintenance of health. Because as Machiavelli wrote, and as a politician of the 16th century, it happens in this, as the physicians say, it happens in the hectic fever, that in the beginning of the malady, it is easy to cure, but difficult to detect. In the course of time, not having been either detected or treated in the beginning, it becomes easy to detect, but difficult to cure. What we do at this time, we recognize very late during the course of the diseases what the problems are, and most of the times we are too late if we act on older persons which had already achieved reached the threshold of vulnerability. We have, so the key words at this point is heterogeneity, and heterogeneity leads to the fact that we have many, many aging phenotypes. And it is about having the possibility to stay between normal and successful aging and avoiding unsuccessful this unsuccessful pathway that develops and that we can really work on, both as doctors and as persons. And the reasons of the causes of age-related diseases are so multifactorial, as we saw many factors influencing the disease onset, then of course we have to have a multi-domain approach to contrast, for instance, cognitive impairment, but also other age-related diseases. In the case of cognitive impairment, we can personalize the multi-domain counseling, which includes nutrition and also exercise and also social participation, and also all these factors which are very complex in their interactions can be personalized and lead to an improvement, a very effective improvement and prevention of cognitive impairment, like for other age-related diseases. And this is scientifically shown. So there is evidence about this. And we have, in fact, also applications, multi-domain applications against dementia development. There is this one, which we work together. Memodio is an app, multi-domain-based app, which counsels about cognitive training, physical exercise, brain nutrition, risk optimization, social participation, and health literacy. And this is what we have to adopt in order to stay healthy. In fact, this is not done because the system cannot allow, for instance, the hospitals to develop this personalized approach. And there is this, for instance, this is the site, a very famous and prestigious newspaper in Germany, which called in the cover page in February, last February, on a very important rubric of this newspaper, rettet unsere Alten, means coming to the hospital. Please save our older persons coming to the hospital. And as I showed here, the most risk is that if we concentrate on the disease on one organ with increasing age, the high risk and the evidence, the fact today is that persons are discharged, are admitted, treated, discharged, and come back, the so-called revolving door effect, which is actually posing and destroying our hospital system because the hospitals are on the edge and don't make it anymore. This is a cover of the Royal College of Physicians of 2014. Just to give you one number, about 1/3 of persons with cognitive impairment come into the hospital for something else. So imagine our Mrs. Lenders of the 3 videos, the 3 scenarios that I showed you, and go out of the hospital without having this properly the diagnosis, because somebody looked at somebody and something else. Why is that so? Because we work with 2 distinct disease models. The medicine works with this model. This is the biological model of disease established in the 19th century, when, however, 80%, this is underestimated, 80% of the diseases were acute diseases. Today, we have 80% of the diseases, they are chronic diseases, and we are still using this biological model of disease, which bases on etiology, pathogenesis, clinical manifestation, and therapy. The other model of disease was developed about 70 years ago. It's called the psychosocial model of disease, which says that it's not about molecules causing diseases, rather intellectual, social, economic factors, and searches for mental, cultural, and economic factors influencing the approach to the patient and his or her health problems. And these 2 models work completely different in a different settings, separately, and every time that we separate models of action, we prevent progress. So what happens to our Mrs. Lenders if she comes with any problem, particularly in this case, a cardiovascular problem, to the doctor, and she has a high biological age, she's very vulnerable according to frailty. She has not a very good chance to be alive at 6 months, and she has a very high chance to be again in the hospital after 6 months. And we have to stop this, and so we have to stop this by looking not only at chronological age and comorbidity or illness of Doris Landers, but looking at the whole person, Doris Landers. And in fact, the approach until now was that each disease is studied by experts, like, for instance, cancer in cancer research, to find cancer therapy, cardiovascular research, cardiovascular therapy, and so on. But in fact, most of these changes that occur with increasing age do not have to be related to one disease, and they don't have to be always treated. And if we treat them, whether they while they are physiological changes, we can cause these iatrogenic effects. And the trend is to recognize that all of these diseases have one main risk factor, which is aging itself. So if we work on understanding better aging and vulnerability and treating maybe also these processes, then we can find not only the treatment of one disease, but the treatment of all age-related diseases. The integration of the two models, biological and psychosocial model of disease, has been described by Engel in 1977 in Science, and says, let's integrate the two models, biological and psychosocial model of disease. Why? Because most of the time it's about all these components together. And in aging medicine, and this is another principle that I would like to give you today, is the aging medicine has this instrument. In fact, since 1985, it was described by Lawrence Rubinstein, and it is now, there is a lot of evidence that this concept works. And this is called the comprehensive geriatric assessment, which contains an assessment not only of the biomedical conditions of the disease, of the person, of the patient, but also on its psychosocial and functional aspects. And there are now many randomized control trials and BMJ reviews and meta-analysis and Cochrane reviews showing that the comprehensive geriatric assessment, so looking at the body, but also at psychosocial and functional aspects, improves diagnosis, function, discharge, behavior, cognition, and keeps under control medication, nursing home admission, hospitalizations, costs, and mortality. Okay, so I give you this prior to a very short bio break, and then we will move to the end quickly. This is something that I showed many years ago. I was measuring micronutrients in plasma of aging persons with heart failure. And what I found was a direct correlation between plasma levels of lutein, a very important lipophilic macronutrient, and the left ventricular ejection fraction of the heart. So the amount of blood that is given out of the heart at each heartbeat, and distributed into the body. So the lower the amount of blood going into the body, the lower the levels of lutein. And this has had a lot of international resonance, and because actually this relationship is not found very often in human studies. You can find them very well in vitro studies, in animal studies, when you look only at two things, but in human studies, when there is this multifactoriality, it's very difficult. And this correlation strikingly resembles the correlations between the number of newborn babies in Germany in 1980 and the pairs of brooding storks. This is a description by Helmut Sies on Nature. Okay, so a relationship between storks and newborns. Or it resembles the correlation published in Lancet in 2012 between chocolate consumption and number of Nobel Prize people worldwide. So this is a pure chance. this kind of relationships that have to be very much critically discussed, which I did in this paper actually, which was published very well. These are not so threatening like this one. The correlation, direct correlation between income and frailty. For instance, in Italy, the difference on life expectancy in former West and East Germany today, and a 30 years difference in life expectancy between Somalia and Singapore, the so-called income and or health and wealth relationship. So these are the relationships that we have to be worried about, the true challenges of our time. And in fact, Rudolf Virchow, a very famous doctor and pathologist of the 19th century, used to say medicine is a social science and politics is medicine on a larger scale. So this is what I give you, future doctors in the audience, and all healthcare and non-healthcare practitioners and representatives of the humanities, economics, ethics, and rights, to be able to understand that medicine and humanities and social aspects must go together to improve quality of life and well-being. The task is to identify this complexity and disentangle it. It's not about avoiding complexity and looking about one thing in a way that we don't have much problems in writing down a DRG disease, an ECD classification of disease, and a good discharge letter. The task is embracing complexity. And so the traditional paradigm, to reverse it in a revolutionary paradigm, to base our diagnosis and interactions with our patients on multimorbidity. There are only 7 guidelines of 300 guidelines which focus on multimorbidity, polypharmacy, biopsychosocial, functional factors. And we use in Cologne one of these comprehensive geriatric assessments. It's called Multidimensional Prognostic Index. Looks at function. These are the activities of daily living, at social factors of our patients, mini nutritional assessment, nutritional factors, short portable mental status questionnaire, cognitive factors, mobility, excellence mid scala is a mobility scala, cumulative illness rating scale, multimorbidity scala score, the number of drugs, and in all, this comprehensive geriatric assessment can be measured, put in this formula, and this formula delivers a continuous number between 0 and 1, where 0 means fitness and robustness, and 1 highest level of frailty. What happens is that frailty is dynamic. You can cure it, but you can only manage it if you identify it. And so what can you do against frailty? You can, through the physiotherapists and occupational therapists, you can improve function and mobility. And with pharmacologists, you can help in reducing polypharmacy through medication reconciliation. You can improve, together with the neuropsychologists, psychiatrists, and neurologists, the cognitive activity. You can improve with nutrition people, with nutrition medicine, nutritional aspects and malnutrition. You can improve with social workers, the social problems of these persons. Usually you cannot so much improve multimorbidity, but you can, of course, on the long run. And at the end, you can improve frailty, prognosis, and level of vulnerability by restoring, in some cases, in many cases, robustness. The requirement is that do you diagnose frailty, and to diagnose it, you have to use the comprehensive geriatric assessment, which bases on the biopsychosocial model of disease. And in fact, we see, if you remember this high hospitalization and mortality risk of Doris Landers coming to the hospital, if you do the multi-domain treatment based on the with the geriatric team represented here, based on a comprehensive geriatric assessment, you are able to reverse and to bring this high level of frailty towards robustness, level 0, score 0 of the MPI. And this was published in the Journal of the American Medical Directors in 2022. So you can go ahead and look for this paper from Anna Meyer and colleagues. And so the next message that I want to give you, it's not from me, it's from Albert Einstein. Everything should be made simple, but no simpler. If you try medicine in the upcoming challenges to make everything simple, you will work only with the tip of the iceberg, and you will forget the person, and this person will be discharged with beautiful letters, but will come back through the revolving door effect. And we showed that, in fact, for cardiovascular problems, these are studies that we are conducting with the institute, with the department, the clinics of cardiology at the University Hospital of Cologne. If you look only at the frailty physical phenotype, only physical frailty of the person, so vulnerability, sarcopenia, muscle loss, physical weakness, you will not be able to detect health trajectories after an intervention of the heart, as well as you do it with the multidimensional prognostic index, because the multidimensional prognostic index, as a comprehensive geriatric assessment, diagnoses the person with the disease, and not only the disease, and not only one aspect, the physical one. Okay, so in summary, so far, the world population is getting very old and overweight. There is a large prevalence of frailty and disability. Staying healthy with increasing age is a lifelong task. Frailty and the intrinsic pace of aging are multifactorial and heterogeneous, and we have to embrace this complexity. If they are multifactorial, their diagnosis and treatment are complex and multi-domain, and we cannot focus only on one problem or one organ or one disease. The comprehensive geriatric assessment disentangles complexity and reduces mortality and frailty. And so with these messages, I would like to encourage you to go to have a bio break, because we talked about many things. And we can meet in 4 minutes again, so get a coffee, get a little pause, and then we get together at 5 minutes prior to 10:30, at 10:25, and we can have then the last part. Thank you very much for your attention.
Thank you very much, Professor Polidori. I will just shortly repeat. Now, a few minutes break. We will see each other again at 10:25. Vielleicht eine kurze Frage, wenn ich darf, Professor Polidori. Ja, gegen 10, also so vor circa 20 Minuten, ist der Ton ein bisschen schlechter geworden. Ich glaube nicht, dass das am Headset liegt. Ich würde eher sagen, das liegt am Internet-Upload, aber nur, dass Sie Bescheid wissen. Ja, also alles war verständlich, alles gut, aber man hat trotzdem im Hintergrund ein bisschen was gehört.
Sehr gut. Ich versuche es jetzt mit dem Headset und Sie geben mir Bescheid.
Ja. Ja, wie gesagt, ich glaube nicht, dass es an dem Headset liegt. Ich glaube, das ist dann eher am Internet, also am Upload. Aber ja, mal schauen. Gerne können Sie das dann auch versuchen mit dem Headset. So, meine Uhr sagt 10:25. Wollen wir weitermachen?
Wir machen weiter, eine Sekunde. Ich muss kurz mit der Klinik kommunizieren. Wir beginnen sofort.
Ja, perfekt. So maybe I could already tell the participants. Now I was going to ask questions, right? So I would suggest if you have any questions that you would like to ask in person, then just write us a short message in the Q&A. Just I would like to ask a question, and then I will promote you to a discussion participant so that we can also see you while you ask your question. But you can also, of course, ask your question in text. But a short disclaimer, if you would like to ask your question in person, you should know that I am recording the session. So, while until now everyone has been anonymous, if you want to ask a question in person or, with your camera on, then of course you would be recorded. And the purpose of the recording is that we will upload this lecture to our website in a few days from now. So just a disclaimer that you know. And
Maybe,
please.
Yes. Are there, I don't, sorry, I see something in the,
yeah.
Okay.
There's already one question, so I would like to, okay, let's see if this works. Can you try asking a question now? No, it doesn't work. Okay, so let's just see. Just a second. There we go. So you should get a prompt now. Yes, there we go.
Can you hear me now?
We can hear you.
Perfect. Professor Polidori. All right. Hi. Thanks for the great lecture so far. I was wondering if you could go more into detail on the preventive perspective on frailty in particular, but with regard to age-related diseases in general. You mentioned the Mediterranean diet is a lifestyle, and I think on this lifestyle level, there are several approaches leading an active life, for example, as some kind of a general statement. And I was wondering if you could go more into detail on the preventive perspective. Thank you very much.
Yes, so thank you very much for this important question. Do you hear me?
Yeah.
Yes, right. Okay. So, yes, I will actually also show you in a minute the several aspects that cover this topic. But actually, diet is also coming from the ancient Greek. It means going through life, and it's about lifestyle, in fact. And the factors contributing to health are multiple, like the factors giving the risk of disease are multiple. The nutrition is one pillar. The balanced nutrition means eating more vegetables than fruits, and in any case, more fruits and vegetables than meat and protein. Having a low amount of carbohydrates, reducing the amounts of sugars, and drinking water, being hydrated. But also this lack of nutritional part has to be implemented and integrated with physical exercise, social participation, cognitive activities that improve quality of life and well-being, not something that makes you upset for the whole time, so to say. As far as age-related disorder concerns, like dementia, for instance, it is important to maintain the sensoric intact, so like hearing and seeing. Sleep is a very important part of health, of the maintenance of health. So the capacity of recover and to have enough sleep, and also going to doing the controls with the doctor. So I always say, go to the doctor when you're healthy and not when you have already a disease. So to maintain really the function. And if I might get the chance of this to show you the last couple of slides, you will see that we have many factors that we don't know about enough. And in fact, there is one big gap that we have between in the science and medical systems, is that for instance, geriatricians and also now almost all medical disciplines work on disability and preventing multimorbidity and preventing functional loss, and working on disease and maintenance and therapeutic strategies. The scientists working on aging science work on mechanisms of aging, like the balance between stress and biological damage and compensation, for instance, DNA repair mechanisms, chaperones, autophagy, mitochondrial dysfunction and function, and telomerase activation. The biological damage, like which is highly studied, are the so-called biological clocks, DNA damage, protein misfolding, mitochondrial dysfunction. These are basically the so-called pillars of aging, the hallmarks of aging, the mechanisms of aging. But biogerontologists and geriatricians or medical doctors do not work together. So geriatricians do not inform bioscience, biological or biogerontological scientists, and vice versa, to improve and move on these completely unknown aspects that determine susceptibility to disease, which are neurodegeneration aspects prior to the onset of disease, homeostasis, so the equilibrium of the different systems in the body, energy, the metabolism, altered body composition, endothelial dysfunction. These are all phenotypes of vulnerability with increasing age that are largely unknown during the course of life until a threshold, which is individual, is reached, and after that, disease becomes overt, and very, very often, the persons coming to us come too late, and then we can a little bit reverse to robustness, but it's very difficult. So one thing is that to adopt healthy lifestyles, to in fact stop or slow down these phenotypical changes that occur with increasing age. I'm sorry, but we have to go many times. When people hear me, they say, this is too much. I know, being a person is too much. And increasing age is too much, and the challenges that we are facing, and will be facing in the next few years are too much. But if we close our eyes and go for simplicity, we will never go anywhere. We need a crosstalk between the different disciplines. Biogerontology working on hallmarks of aging, this layer here. We have to talk to each other. The frailty phenotypes here, endothelial function, circadian rhythm, body composition, neuroendocrine changes, neuronal changes, sensory perception. It is something that we have to start to consider. The geriatric approach, the comprehensive geriatric assessment, the person medicine, the person-centered, goal-oriented, value-based approach, which includes ethical aspects and psychosocial aspects, is fundamental. But if we don't have any access to the healthcare setting, we can have the best doctors ever and don't reach and balance these social inequalities. And at the end, the society, the ecosystem. One thing is to be in a place now where we have war or an earthquake, and one thing is to be in very safe environments. So this is complexity, and if we neglect this complexity and we don't disentangle it, for instance, by means of the comprehensive geriatric assessment, we will never get a sustainable way to move. So there is, for instance, the possibility to focusing on oxidative stress on the hallmarks of aging. So this is one of these parts here. Mitochondrial function, free radical production. This is only one of the hallmarks and mechanisms of aging. We do it. We did it for many years. It is very important to understand these mechanisms. But of course, alone, we will not solve with vitamins dementia. And this is the fact that, that we didn't learn to embrace complexity. We can, if these are all the factors known until now to influence the transition from healthy to pre-frail to frail and vice versa, we cannot neglect only focus on one. We might do it to understand some things, but we have to consider that at the personal level, the other factors will be important. The same happens for if we want to focus on metabolism. The same happens, sorry, it doesn't move. So this is the complexity. Now we have the omics at their disposition. We work on omics and networks of substances that appear to be quite important or more important than others in influencing, for instance, kidney disease. But this is only one aspect, metabolism here. You know, this is one of these many. The next would be this one. This is metabolism. The next would be chronic inflammation. Inflammation is a sterile chronic condition of inflammation that we never diagnose, but it actually profoundly influences the lethality through SARS-CoV-2 infection, which destroyed basically the generation of older persons, which have already many age-related changes, which increase the frailty and vulnerability to COVID-19. And immune senescence and inflammation are tightly related and create this chronic inflammation that is possibly related to oxidative stress as well. It's a very complex condition that must be studied very precisely. A biogerontologist probably influence the fact that life expectancy is much different in men and women, and we urgently need gender medicine, which is not done until now, not on a systematic way. We have to include age-related changes like immune senescence and inflammation in the correlations between cancer and in autoimmune diseases. Otherwise, if we don't include age-related changes like inflammation, we only look at the tip of the iceberg and will not resolve the problem of these two dramatic diseases. And at the end, and I would like to conclude with these two very famous geriatricians that published already in the American Journal of Medicine already 2004, the different approaches. So if Mrs. Landers, in the video that you saw, comes with exhaustion, for instance, and weight loss, and we look at the disease approach with appetite loss, we start to look for organs, and we want to exclude that we are having cancer, and we will look about one therapy. Okay, if we move the perspective, this is the universe seen from Caravaggio, some gods working with the playing ball with the universe. This is the Earth and this is the Sun. This is the vision of the Voyager 1 in 1991. This is the pale blue dot, the vision, a picture of us, of the Earth, sent back to Earth in 1991. If we change this perspective, we will see, and these are actually all these very rapid changes have occurred at the very end of the tip of our finger. If the history of the Earth is represented in a complete forearm, okay, so this is really, really quickly what is happening. If we look at the three Doris Landers from the perspective of Deutschlanders, we will look at the worries of the patient and see that their worry is not having a particular cutoff or lab value not under control, but it's not possible anymore to take care for her of her grandchildren. So we will, of course, do the disease-based approach because we are doctors, objective evaluation, but then we will look at the priority of the person, and non-biologic factors, at psychosocial factors, at factors hindering goal attainment for her to go back to take care of her own family, and then look at the therapies and the outcomes based on the priority of the patient. I would like to say that EUniWell, that my approach and exposure to EUniWell was through this initiative from Dr. Yue Tsao from the surgery department of the University Hospital of Cologne, which wanted me to go together with her, with surgeons, and a mother of geriatrics was, in fact, a British surgeon, together with educational representatives, informatics, public health, surgery, oncology, to work together for the aspects of biological age influencing the development of disease in a person with increasing age and frailty. And we produced educational videos, international videos, together with these universities, with this consortium, to teach and show the importance of being increasingly frail and having an increased biological age, and the challenge is to work with a patient with only cancer, or to treat cancer and diagnose cancer, or to diagnose and treat the person with cancer, which is a very different approach. These are some of our initiatives to improve awareness about quality of life and well-being, the days of mental fitness organized for the citizens. We are writing books and publishing podcasts to maintain our citizens healthy, and we included in nutrition medicine in the medical curriculum. We have, and I really invite you to participate to the advanced innovation and entrepreneurship course of the AIT Health Aging PhD schools, starting on April 17th for 2 weeks, 2 hours per day. We will have the major worldwide experts of sarcopenia, dementia, biological aging, frailty and immunity, psychological aspects, career development, biomarkers of aging, living and dying in advanced age, digitalization, technology, industry, on the aspects and the challenges of aging medicine in the future. And we always, we invite you, and this is for the medical doctors, but you can come to us to Cologne. The medical students will undergo very soon the block practica, so the practical days where they will have the chance to increase their own biological age with these simulation suits and see how difficult it is to lose sensory perception and movement at the same time being seen by doctors. The language is very important, and I wish you to mind the gap to these gaps that I showed you in silos thinking. Please avoid this silo thinking, embrace complexity, and change the perspective. These young people are young people in Cologne working with us and exploring this complexity. They decided to embrace complexity. Some of them decided to remain in aging medicine and geriatrics. And all of you, I kindly ask you, let's stop this going out, this flowing of the water while the doctors and other workers, social workers, and humanities representatives worldwide try to clean the floor while this water is still flowing. So please turn this off And you can do it by improving prevention, health maintenance, performing the comprehensive geriatric assessment, thinking on the basis of the biological, the biopsychosocial model of disease. And I thank you very much for your attention.
Thank you very much, Professor Polidori, for this very interesting lecture that even for me as a non-medical expert was very enlightening, and I learned a lot of new things. So I can only imagine what the actual experts in the audience all learned and could take with them. So I think now we can ask some more questions. Erik, I believe that your question was answered. Is that right?
Indeed. Thank you very much.
Thank you very much. We have someone who would actually like to ask a question as well. So David, I will promote you. Just a second. Must have gotten a prompt now. Yes. There we go. If anybody else wants to ask questions, again, just either raise your hand or let us know through the Q&A button down below.
Morning.
David, we can't hear you, unfortunately. Now something's happening.
Hello, hello.
You're very quiet, very quiet.
Yes, sorry. Now it's better? Now it's better now?
Just marginally better. If you could make yourself even more loud, would be perfect.
Okay. Thank you. So morning. So congratulations to Cristina Polidori for the talk. So in this new scenario with lots of people with long-term conditions and chronic diseases rather than acute conditions. However, in this scenario, our national health systems focus or channel all the money to the hospitals, and the hospitals are the main infrastructure to deal with patients, despite this new scenario with patients with long-term conditions and chronic diseases. My question is about what kind of infrastructure we need to deal with these new patients now and in the future. I mean, maybe
Yes.
in the future, the universities, in addition to university hospitals, may have university rehabilitation centers or universities, older adults care center or wherever. I mean, we need to change the infrastructure, I guess, to deal with this new situation. Thank you.
Thank you very much, David, for this important question. So I briefly repeat, David is saying what in this scenario shows that if patients arrive to the hospital and resources are based in the hospitals, we might be unable to cope with the challenges that I showed. David, can you mute yourself? Can you please close your microphone, because we have some, thank you very much. Sorry for this, thank you. So yes, you're right. I personally think, and this is something that we will have to do, and there are some efforts already, to move from a lot of energy in the and resources, of course, manpower and money in the early detection of vulnerability. So we have this increasing age, and we have to work a lot together with general practitioners, because general practitioners have to use, and they do most of the times, but they are not enabled, for instance, in Germany, to use effectively the comprehensive geriatric assessment, because you need geriatric expertise, and you need the time, not more time the way we think, but we have, of course, the mentality and the approach to the patient is different, and there is no training for medical doctors to this approach in order for them to understand that this is feasible. It's highly feasible, in fact. So the interaction with general practitioners in the territory must be much more effective. And we have to catch people before they become very ill with frailty. I think we need specialized hospitals treating persons and at the same time pre-rehabilitating persons at risk of frailty or with frailty. When they need high performance medicine, you cannot avoid hospitals, of course, but the selection of persons arriving into the hospital must be much ameliorated. So I fully agree with you, and we should maybe with EUniWell converge and merge our possibilities to improve actions aimed at detecting frailty, biopsychosocial frailty in real life in the community, and enabling a good stratification of patients reaching the hospital, avoiding futile clinical decision-making and redundancies. Yes, you're absolutely right. We have to do that. And we have to do that moving together.
Thank you very much. David, does that answer your question?
Of course. Thank you. Thank you very much, Cristina.
Thank you.
Thank you. So are there any more questions that you would like to ask?
I don't think so, right?
Does not seem to be the case. That's very, very detailed and indeed exhaustive in a very positive way, your lecture. Thank you very much. So thank you for this lecture. Thanks to everyone for participating and also for the questions that you have asked. And I can only ask you to reflect on what you have learned today and to put it to practice in the future. And maybe we will see each other again in future events, or maybe I will be your patient in the future. We will see.
We hope not. I thank you all. I thank you, Mr. Egger, for the excellent moderation, and I thank all the audience. And you can reach me and find my email address in internet. If you have questions, don't hesitate to ask, and please visit us in Cologne, because we have the first Europe-wide sentinel experiment of a clinical setting, admitting persons at risk of frailty in need of high-performance medicine being or rehabilitated until discharge in good function. And in this sense, I wish you a very nice day and season's greetings and holidays. Bye-bye.
Thank you very much, and goodbye, everyone.